The FIND-AF randomized trial is a trial we did in Germany in 4 study centers. We know that atrial fibrillation is a major risk factor of stroke. And we think that a lot of stroke patients have atrial fibrillation that we do not detect when we just do usual care monitoring, which is, on general, 24 hours of holter ECG monitoring and 3 days of telemetry on the stroke unit. So in this trial, we randomized 400 patients to an intervention that we called enhanced and prolonged monitoring or usual care. Enhanced and prolonged monitoring means we did a 10-day holter ECG, that's longer than usual. We did this at 3 time points, at the time point of the stroke, after 3 and after 6 months. And we did it enhanced, which means we had a core lab where all the ECG data was analyzed. The primary endpoint of the study was published 2 years ago in Lancet Neurology. That was how much AF do we find within 6 months, and we did find AF in 4.5% of patients in the usual care arm and in 13.5% in the intervention arm. This means the number needed to screen is 11. I have to screen 11 patients by this 3 times 10-day holter ECG to find 1 case of atrial fibrillation. What I present here is the long-term follow-up data for up to 3 years, and what we did find after 3 years is that the difference between the 2 arms diminished, and that during follow-up we did find significantly more AF in the control arm, and in the end we had similar numbers of atrial fibrillation in the intervention and in the control arm. This means atrial fibrillation by our intervention was found earlier than it would usually be found under usual care. And we looked on an exploratory basis on the number of strokes, TIAs and death. We would think if we treat atrial fibrillation better because we diagnose it, we anticoagulate these patients, then we reduce the burden of stroke. The trial with 400 patients is not powered for this endpoint, but where there was a positive trend. We had something like a 40% reduction in the number of patients who had a recurrent stroke. We had less TIAs in the intervention arm than in the control arm, and we had less death in the intervention than in the control arm. In this context, it did mean a 10-day holter ECG monitoring that was started just after randomization. Randomization occurred 3 days after symptom onset for the stroke, and this ECG was repeated after 3 and after 6 months, unless atrial fibrillation was detected in one of the previous holters. So if atrial fibrillation was found in the first holter, we didn't do the second or third. So we can say from these findings, by the intervention, we do not find more atrial fibrillation, but we do find atrial fibrillation earlier than we do under usual care conditions. And interestingly, we defined atrial fibrillation in accordance with the guidelines as any episode of more than 30 seconds. And we see for the first time that these episodes we see for more than 30 seconds in the 10-day holter monitoring are precursors of atrial fibrillation that usually comes years after that as clinical apparent ECG on a 12-channel ECG. The implication for clinical practice, I think, is we have to look more for atrial fibrillation in stroke patients. In Germany and in other countries, the problem is that this at the moment is not reimbursed, so we need other reimbursement systems. And the open question is, do we only find more AF, do we reduce the burden of stroke? I think that looking for atrial fibrillation in stroke patients is a secondary prevention measurement with a chance to have a 30% risk reduction in the risk of recurrent stroke. And we need an adequately powered trial to do this, and we're just at a very final stage to get this trial funded, which would be a trial with nearly 5,000 patients. But it would answer the question, not only do we find more AF, but does the finding of AF lead to anticoagulation, and does this in the end lead to a reduction in the risk of recurrent stroke?